My name is Holly Richter, and I'm going to talk to you today about kind of an experiential update in my clinical management of apical prolapse. And so probably, I think since 2005 or something like that, we've been using the Capio suture device. And we've used it with great success. My colleagues in the Pelvic Floor Disorders Network have used the Capios. I learned some tricks on using the Capios, but you have to, as a teacher, and even as somebody who, if you're doing, you're doing them, your fingers on there, you've got the Capio head on, you're stabilizing it, you're firing. That act of firing can displace that head off the ligament. It can take it back. Maybe it's put a little anterior, and you're just not getting a consistency in the amount of ligament you get every time. And so, I've really been thinking about this for a long time, and decided to switch to Anchorsure. And my experience with Anchorsure started in 2017 when I met Javi at the ICS in Phoenix, and I went to his little table, and it just kind of made sense to me. So that's in 2017. I didn't start doing them consistently really until probably this year. And you see, it's been around a long time, since 2009. It was part of a transvaginal kit, the SureLift, which I had to look up. But a transvaginal mesh kit. It received 510K certification, FDA approval, and a lot of Anchorsures have been used up to this point. There's a reasonable efficacy data and adverse event data, and to my understanding, no MOD reports have been made with regard to the Anchorsure. So what is it? It's fixation with a biocompatible anchor made of polyether ether ketone, or PEEK. And it's a very inert, thermostable type of hard plastic that's used by the orthopods. It's not a foreign thing in the surgical world. And it looks like one of those little burrs that, stuck in your feet when you used to go barefoot in the yard and stuff, where they get stuck in your sock. That's what it looks like. It has good anchoring strength. It can withstand 40 to 50 newtons of force. That paper's right here. I had to read all these papers and really think about it. And then I talked to people who were doing it, and they liked it. I'm not a rapid adopter of new technology. It kind of makes sense that you would minimize nerve entrapment, because you could really encircle a nerve with the use of a Capio suture type placement. It's proven efficacy. It's compatible with synthetic or biologic meshes. I don't use it for mesh. Some people do. And you can put any type of suture. I usually use a Prolina PDS or all PDS. And until very recently, and I wasn't going to use it until I knew I could put 2 sutures through that burr. And I used to have to shave an end and slide it through, but now they've made that little hole right there where you feed the suture. They've made it a little longer now, so you can easily place 2 sutures. Just as with the Capio or Maya hook or whatever you use, the anchor should be placed at least 2.5 centimeters from the spine. And the beauty of this is, you see that it's a metal cylinder that you affix right on the ligament. And there's a finite depth that this can go, 11 millimeters. And you can be right on the ligament, not oriented toward the vessels or nerve, but right going into the ligament. To me, it's a much more direct placement of sutures in the ligament. So this is the complete system. Now this hole's a little bigger, so you can easily put 2 sutures there. And I always use our own Mayo-free needles. There was a recent trial of a randomized trial of Anchorsure versus the use of Capio, published in Green in 2022. And apparently this was kind of an early experience for Matt's group, and basically they queried the surgeons with regard to their overall experience with the anchor. About 50% said it was excellent, about 30% very good, about 17% satisfactory. I too agree that it's to me, there's increased surgical efficiency with it and ease of use. And I think there's our fellows here and she can say something, but I think it's much easier to teach as well to our learners. So there was similar post-op pain, surgical performance to the suture capture device. They looked at outcomes, POP-Q measures, no patients with significant pain at 6 weeks or any anchor related issues. And it's pretty easy on the early learner.
Looking at the anchor characteristics, she already mentioned, that it's made out of this PEEK material, which has really been used for years in orthopedics. They're actually now using it in face as well for orthopedic reconstruction. So it's a safe material. There really is nothing to react to. It's very biocompatible. But the difference with this tip, and she started talking about that a moment ago, was the pyramidal nature of the 3D tip versus the other tips or anchors that are available. So it really has a 4-point fixation tip, which is not just unidirectional, but bi-directional way. She talked about the pull-out force and newtons. I don't know about you guys. I really can't understand newtons. So to me, that's about 9 pounds, just so you understand that. I don't talk about newtons very often, but we all put it in the literature. Isn't that interesting? But the suture, as she mentioned, can be easily changed. I keep the suture myself. I like the Proline, but as she mentioned, you can change it to any suture you want. So if there's something you prefer, certainly can do that. And minimizing the nerve entrapment, I think, is key, because that's the part that gives us, keeps us up at night, right, with these patients in the past. And I think if you've done enough sacrospinous ligament fixations, you've taken at least one back to the OR weeks later where the pain just didn't resolve. I mean, we've all seen one of those, right? So you really or minimizing the effect of that, or the ability for that to even happen. And for me, I switched. I was a mesh user, so I was really used to using anchor ideas already with single incision mesh fixation, whether it be the Elevate or the Uphold I had used as well. But with the old Elevate system, we were anchoring, and when that got taken away, I really was looking for an answer. And I sought this system out myself because it was the most compatible with what I knew. I was already very comfortable with the anchor technique and the safety of that, and the efficacy as well. So I liked the idea of being able to tack something to the ligament without the through and through suture of a capio or a ligature device. And also not worry about, well, can I put this in my graft? So I can use this with any graft. I can still use mesh if I want, but I can use biologics as well, which I've started using quite a bit after mesh went away. The straight applicator, some people at the beginning think, well, is that straight applicator going to be problematic? Honestly, it's simple, it's easy. So while, yeah, maybe a curved applicator could be nice in some situations, it really isn't limiting to the surgery. You still need a very minimum dissection technique, which I'm also a big fan of. I'm a minimalist when it comes to dissection. I think the least disruptive we are to tissue and surrounding nerves and vessels, the better. I've always liked that idea. So the fact that you don't have to expose like you did in the old days and get the briskies out and look at the ligament is really important to me, as well as the profile of this is so slim. You really need, if you can clear out a fingertip on that sacrospinous ligament, you can deploy this. That's literally all you need. And I think we can pretty much do that in any patient. I mean, I've used this in patients who had prior surgery in the sacrospinous before me somewhere else, and I've been able to deploy this. So it really takes very little dissection. So you can look at the comparison of the heads of other devices, and you can see clearly the slim profile and the need for less dissection. And you really are catching that tissue that you do when you're using, say, a capio type device, where you just can't quite get it positioned well. And, you're maneuvering your body in all these different, contortions trying to get it right. With this, you really don't have to do that. So the shape, I think, is really the biggest difference. That pyramidal shape, if you think about it, I'll show another slide in a moment, is really what's going to help your pull-out force. And the fibers, you have to think about the fibers of the ligament and the tissue you're going through, as well as how that tissue is that anchor is going to lie in that tissue. So if you look, at the comparison, there was a comparison when it was used as sure lift in that mesh kit she mentioned earlier. It had, a very high pull-out force compared to, say, mini arc or other devices were out at the time for fixating mesh. If you look at the pictures there, showing it in the directional functionality photos, you can see that if your fibers are running, east and west, and so is your anchor, they could pull out, right? So the benefit of this anchor is that pyramidal nature, in which if it goes in backwards, turned around at a 300 or 180 degrees, it won't matter. Whereas if you have a unidirectional anchor, that direction could matter. So, time will tell, but I think, you really don't have to worry about it because you have the pyramidal shape. Again, just looking at other anchor techniques and the differences, the Ancashire shaft being only 5 millimeters in total. Again, just looking at the sutures. So the sutures of, say, the new Saffron device are external. Theoretically, they could pull out while you're placing that anchor. You have to worry about those not sliding out because, again, those come out too. You could change that suture. That's not going to happen with your Ancashire because it's buried inside the shaft. So you're really not going to pull out the sutures as you're placing them, which would not be so great. If you get that anchor in without its sutures, you'd have to deploy a second one. Speaking of which, she mentioned the kit comes with 2 anchors. But I always have my OR staff keep, you can buy separate anchors, so you could open them as needed. So if for some reason something happens, you need another anchor, I always have one available as a backup. I'm always a big fan of backups because things happen, something gets dropped on the floor or whatever. So you can get those separately. Again, the complete system she showed you, and I use the free needle it comes with, but you can swap out for your own free needle if you find that those are easier for you to place. And then you've got that pulley system technique that they showed you in that video that helps you if you do want to attach either to your tissue or your grafts or whatever you're going to be attaching to, that pulley technique does it helps you to get those sutures down effectively. And the depth minimization is key. You really can't go too deep. It keeps you from injuring any of the neurovascular bundle, should you be close to that. Again, talking about the anchor technique, and I think a lot of people are afraid at first about anchors. There's a lot of fear I initially hear when I talk to people who've never used it, because they're worried about leaving this little 5 millimeter anchor in place. We really should be afraid of that. We leave how much transvaginal mesh in when we do a sling? So that little anchor has never caused me an issue. I've never felt it. I've never had a patient feel it. And yes, I've had to replace one and had to leave 2 on one side, and it's not the end of the world. It's fine. The Ancashire was FDA approved in the US in 2012. However, it was used since 2008 in Europe. So there are some other studies that pre-existed us looking at these anchors and their safety, their pull-out forces. So this was a study looking at the pull-out force, comparing different anchors in similar tissues, which showed that great pull-out force. And this, looking at just like Capio, for instance, in Walter's study, 55% of those patients had gluteal thigh and buttock pain or thigh pain initially, with 15% persistent at 6 weeks. But in 300 cases of Ancashire, there was only 1 case of persistent pelvic pain. So I'm going to kind of argue that my data is very different from what Dr. Matthews had in her study as far as prolonged pain. I think, you do see maybe some initial buttock pain that's transient, but it's very rare that I'm hearing anybody talk about it at 6 weeks, and literally 0 beyond that. This is one looking at unilateral sacrospinous fixation with mesh. It's looking at safety and efficacy, which was confirming that Ancashire did give good safety and efficacy. And then another one looking at its use actually under local anesthesia, which is very interesting. Because it's so quick and easy, which I'll show you my video of me doing it in a moment, you can actually do this under local. So this is really kind of an important thought as far as thinking about your high-risk patients, your patients who maybe you're thinking colpochliosis and saying, well, maybe I don't need to do a colpochliosis. Maybe they don't want a colpochliosis, but you want something that you can do under local anesthesia. This is actually an option that most people don't think about. And then looking at a study that was presented at SUFU, it was comparing, sacrospinous technique using the Ancashire versus traditional suturing or Capio. They saved 34 minutes, but with similar outcomes. So there's that, we're saving surgeon time, patient time under anesthesia. I started using the device in April 2019 when mesh magically disappeared from the market. and I had to find an option. So I've done 166 cases of Anchor. I do a bilateral placement personally, and most of these, if not all, were for anterior and apical prolapse, where I actually attach a biologic graft as well in place of my mesh, kind of in the shape of an uphold going all the way down to the sacrospinous ligament and attaching my sutures to that, as well as oftentimes a cervix. So the majority of mine are actually hysteropexies. It's really decreased my need for doing vaginal hysterectomies at this point. And through an anterior approach, which a lot of people are not always used to or think about. There's a lot of people out there who won't do an anterior approach, but it's excellent. And it actually gives you more anatomic correction if you think about the hysteropexy technique and the tilt of the anterior vertebral uterus, if you think about it. So I've had 0 reoperations. Now, I always hate to say the word 0 as a surgeon. I mean, I'm not lying. I really haven't. And not to say there might not be one out there who's, you know, a stage 2 prolapse who's just asymptomatic at the moment, but nobody has had reoperation, and especially for complications or buttock pain. And I think that's the biggest reason I looked at going to an anchoring technique to begin with. How can I get a good outcome similar to other techniques, but with less risk and complication, right? That's always our goal as a surgeon. How can I update my technique and decrease my risks? And I feel like this has really helped me do that. There you go. So my dissection's already completed in the anterior compartment of this patient. That's me. I always check my tip and I always push it back in myself. I always load them myself. I trust no one. So I always start on the patient's right side. And your fingers really have to be your eyeballs. You have to know your anatomy. Deployed, pull out. I either hand them off or I'll tie this or clasp the sutures to the drape. And then I'm loading my second tip, which I always do myself. I trust no one. And I always check my tips in my device. Make sure there's no manufacturing issues, place it on myself. And I like to use my Adson to place them on the tip sometimes or take it out, just makes it easier. And I put both sutures on either side. I don't put them on one side. I just like it that way. I'm a purist. I load it, pop it down to make sure it's covered. So that covers it so it doesn't drag any tissue as you go in. And there goes the left side. Push the blue knob. You can audibly and tactily feel the pop. So that's the other nice thing about the device. You will definitely feel it, and oftentimes you can hear it. So you know you're in good tissue. And that entire process took 1 minute and 21 seconds, that video, which I did live one day in the OR a couple of weeks ago. So that's the process. It's very fast, very efficient, and reproducible. And I do it the same way every time, period. So that's my technique and that's my experience. And I open up the floor to questions.